I'm going to introduce Dr. Emanuele Giorgi, who's here visiting us. He's a professor of biostatistics at the University of Birmingham in a team that has a very cool name. It's the BEST team.
I didn't give this. I mean,
which stands for Biostatistics, Evidence Synthesis, Test Evaluation, and Prediction Models. Yes.
But the name of the group I belong before is even cooler, and I'll introduce it in a second because I still have everything.
And so,
okay.
Yeah, Dr. Giorgi does geostatistics and applied especially for public health, and you develop methodology as well. And yeah. And also you make it very applicable for policy.
I hope so.
Yes.
Thank you.
So very excited, and thank you.
Thank you. Thank you. So if it's okay, I will sit. Okay. Yeah. So thank you for the introduction. Especially thank you for the invitation. I'm really honored and hope to get to meet every one of you and have individual conversations. So the spirit of this presentation is really more an introduction of what I do in very general terms, in very broad terms. So there is nothing going to be very technical, and I'm not going to focus on a single, project that I'm working on. It's just a way of introducing myself, and hopefully will help us to then develop a few conversations that will follow. You can see that this is actually showing still an affiliation with Lancaster University, because my move to Birmingham has been very recent. It's less than a month that I moved to Birmingham, and I still retain an honorary position at Lancaster University, where before I was leading the Center for Health Bioinformatics, Computing and Statistics, which is abbreviated as CHICAS. And the name was given by a prominent statistician, Peter Diggle, but he didn't speak Spanish at the time. I honestly don't mind, although there was no woman when actually the name was given. But I think we improved. Actually, now they are the majority. So I still have my affiliation with Lancaster, although I'm physically based in my primary affiliation is Birmingham, where I began. Okay, I'm just trying to switch. Okay. So just to give you an idea of my background, which is a lot of statistics, essentially, I did my MSc, BSc, PhD in statistics. It's only when I did my PhD I started to apply my statistical knowledge to problems in public health and epidemiology. Although my very first publication is actually in finance, just to give you an idea. I was very much interested in the theory of statistics, but then I was just speaking to a group of 10 people across the world, and I thought I'd like to use this to actually make a difference to the people's health. So today I'm going to give you an overview of what is probably 80% of my research, and I think one of the great strengths of geostatistics is that it can really be applied across diseases. And it can be tailored to the specific etiology of a disease. But the one that I focus a lot these days are neglected tropical diseases. The reason being that there aren't really. So we started working on that field like 5 years ago, and then I think people started to see the benefit of actually using this approach to map, especially neglected tropical disease, but also understand the impact of interventions. And we now are a WHO collaborating center on geostatistics for NTDs. So my current and future research. Tomorrow I'm going to talk about something which is my, let's say, current / future research, which actually is not about geostatistics, but I hope to link with geostatistics. And then, today I think two other important pieces of this work is policy, how we inform policy decisions, and then capacity building. So starting with the neglected tropical diseases, which is, I think, one of the areas that motivates a lot of my methodological development. So neglected tropical diseases are a group of diseases, and the name neglected tropical disease was first coined in 2005 by the WHO. to bring together, I think, a group of diseases that were not attracting much interventions and research development and also investment for control by governments. And so the idea was to bring all these diseases together, which consist of very different diseases. So we're talking about viruses, parasites, bacteria, and together essentially have more of an influence on how governments make decisions and protect their citizens' health. Because this, as I'm going to talk in a second, these diseases affect many people worldwide, especially people in poor countries. So majority of entities are in sub-Saharan Africa, and then we also find them a lot in South America and in South Asia. So neglected tropical diseases have this name because these are not diseases that necessarily kill you, but you develop, since you are a child, you're exposed to them and for a long time, and then they become, really chronic diseases. And because these are not people, these are not diseases that necessarily have a lot of lead to high mortality rates. The way we quantify the impact of these diseases is more through dailies, but also economic impact, because this prevents people from having a normal mental, physical growth, and they can function as normal human beings. But from a geostatistical point of view, and the reason why we're using these methods to understand neglected tropical diseases is that there are some common factors that all these different diseases have together. And to make a long story short, is that all the great majority of them are environmentally driven diseases. So especially wash, so access to also clean water is one of the key factors for many of these neglected tropical diseases. Access to healthcare, but also, depending on what are the routes of transmission, the exposure to the vectors tends to be mediated by environmental characteristics like elevation, humidity, and so forth. Honestly, if we really think about this, these are factors that are not just common to neglected tropical diseases, but to many other kinds of diseases. So as you can see already, geostatistics can be applied to these diseases, but also beyond. And I will probably return to this point, but it's not just infectious diseases that we use geostatistics, but anything that has, say, a spatial environment, in a spatial component. I use geostatistics even to model life expectancy in Liverpool, because deprivation is social deprivation is a spatially structured phenomenon. But geostatistics originally, having just a few very brief conversation with some of you already mentioned the name kriging. Okay, this is because the origin of geostatistics is almost, we consider, outside of the field of statistics, and it's in the engineering, in a mining field in South Africa, where we and the name kriging that some of you already are familiar with is in honor to a South African engineer, Daniel Krige, who first developed this kind of geostatistics discipline as a self-contained discipline with its own terminology and methods outside of statistics, and he used it to solve problems, of how much gold am I going to extract from this area. And rather than digging all over the place, you just collect data from a few sites where you measure how much gold or ore you can extract, and then you try to infer how much you're going to get if you dig in other places. So I'm going to give you now, but the thing is, so the point, what's the connection then? How do we go from this, from mining industry to epidemiology? The thing is that in statistics, this is not the first example, but the methods are developed in an area, and then as time, there is a kind of virtuous cycle where those methods are then taken and applied to other areas. And this happened also, with geostatistics. First originated in engineering, it then started to be applied in environmental science and also in epidemiology. Although I'd say that still the applications of epidemiology, although they have been increasing, there are still, I think, as I will say at the end of this talk, there is a great shortage of people with these skills that apply them to epidemiology. So the first example, and the one that I would like to use to justify the use of geostatistics, is river blindness or onchocerciasis. So I don't know if you have ever heard of this disease before. It's a neglected tropical disease, and it's transmitted by a black fly. I think genus, well, I don't remember the name, but I think Simulium is the genus. And so through repeated bites of this black fly that breed along fast-flowing rivers, there are say young larvae, which are called microfilaria, that get into your body, and then these larvae become adults. They also migrate to different parts of your body, and they also can end up in your eyes and cause blindness, which is why it's called river blindness. The name river is because these flies are breed along fast-flowing rivers. And the other name is also onchocerciasis, because the parasite that these mosquitoes bring is the Onchocerca volvulus. Anyway, I'm not an expert, an epidemiological expert. As you know, as a geostatistician, I get to know many different diseases, but I never have really, honestly, the time, but also the need, if I'm honest, to go to very deep in the epidemiology, also because I don't have the medical background to, I think, fully appreciate what I've been reading. But I think, what I've introduced to you is already enough, I think, to allow any one of you to probably start thinking about how to use geostatistics for this data. So this is a data set that actually I loved, and I still think one of the best data sets I've ever analyzed, and it was during my PhD. So these are more than 14,000 surveyed locations across 20 African countries that participated in the so-called African Program for Onchocerciasis Control. So just to make the point that the countries that have not participated doesn't mean they don't have river blindness. Okay, so this analysis is restricted to those countries that participated in this program, and they carried out national surveys. So here a location represents a sample community, and from each sample community we get the number of people who have been tested for the disease and how many of these individuals tested positive. So here the test was done using nodule palpation. So the idea of this program was to try and find a way to diagnose onchocerciasis in a cost-effective and also efficient way, because the gold standard here would be to take a biopsy test, but because of lack of lab facilities and also for the time it takes to do this kind of diagnosis, they instead use this, if you want, quick and dirty, but probably this is a bit of unkind. Palpation is subject to more bias, if you think, because a medical expert may sometimes misdiagnose a disease. Because the nodules, I didn't say, but we have nodules in river blindness. I don't know if here you can see them somewhere. Yeah, essentially there are these larvae that when they die, they also tend to accumulate, and then they form these hard bumps into the skin, and so someone palpating that hard bump, they could then make a decision whether this is onchocerciasis or not. So this is the kind of test essentially that was carried out in this survey, and so you can see this. If you know basic statistics, you know that this is a kind of binomial data set, because you have a number of people tested, then out of those people, a certain number was positive. So geostatistics is essentially the answer on how do we formulate a statistical model that analyzes this kind of data, but tries to take, to incorporate also a spatial element. So essentially extend what we know as a GLM, or in this case, logistic regression, but bring in also spatial correlation into that model. This is really the most basic is an extension of geostatistics. So the main output is going from this map of raw data to the other map on the right-hand side, which is, in this case, the probability that river blindness prevalence based on nodal palpation exceeds 20%, because the decision was being made at the time on whether a location was exceeding this threshold, so that if it was going to exceed this threshold, then mass drug administration would be performed. The red areas here are areas where it's very likely that we get, we're exceeding 20%. The green areas is where it's very unlikely, so they don't need MDA. And the yellow areas where there is a 50-50 call. So that's essentially an area of highest uncertainty, because with equal likelihood, we are either above or below this 20% threshold. So in my course in geostatistics, I usually introduce this, and then what I teach is how do we, what I hope at the end of this course we'll be able to do is, when I give you this kind of data on the left, you then can analyze and generate the map on the right on your own. But I think there is another point you have to make, which is about the use of this exceedance probability. So rather than conveying the risk for disease in terms of the estimated prevalence, we use exceedance probabilities, because these more directly answer the question around the policy question of exceeding a threshold. So it would be wrong to essentially statistically, wrong probably is not a too strong word. It wouldn't be the best statistical approach to show the map of predicted prevalence and then locate the locations where we are above 20%, because that would be fine if that was a map without uncertainty. But because we have uncertainty, we need using these exceedance probabilities is a better approach. So what is the type of model that we use then to really go from the map with the raw data to the one with the surface? So these are the most basic ingredients, and here I'm giving you the simplest possible version of a geostatistical model for prevalence mapping. So we have an outcome. We also have the number of people who have been tested. As I said, we need to know the locations. In this case, we know the locations of a community. So that's important, meaning that I'm not working with area level data. Although if you want the communities, strictly speaking, is also not the point. It probably is an area, but relative to the scale, I think, of the phenomenon that I am trying to model, it can be approximated as a point. So this is a subtle point, but worth making. And then there are covariates, elevation, distance from waterways. So these covariates usually are proxies that we use to capture the distribution, in this case of the vector, because we cannot get direct information on how many black flies are in a location, which would be, I think, more informative. But I think because it's very expensive to collect that kind of data, and also there is also a lot of uncertainty. This number of black flies can be, influenced by many things. Even the time of the day that you observe them can really make big changes in that number. So rather than using vector information, which is something I think we should explore more, even in geostatistics, we use proxies, because they are easily and cheaply available with satellites or other model-based approaches. And then we use so the spatial Gaussian process is the fourth and key element here, because it's a spatial, so it's a random effect. I don't know if you have ever done random effects models, but it is essentially a random effect, and it's important to call it random effect because when we say random effect, we are implicitly saying that this is a random variable that is accounting for the effects of other unmeasured covariates. And because we cannot measure those covariates, we model them as a stochastic process. So the usual assumption that we make here is that it's stationary and isotropic, meaning that, I'm not going to detail what this means, but this assumption implies that we can formulate the spatial correlation as the distance between locations. Okay, so it's these two sets of assumptions that can allow us to write the spatial correlation as purely a function of the distance, meaning that if two locations are aligned north-south or east-west, as long as the distance is the same, that correlation would also be the same. And you can, essentially, this is probably a wrong assumption if there are directional effects. Essentially, when there are directions where you can expect a stronger correlation than in another. But this is an assumption that is usually made because it's very difficult to identify those directional effects that I've mentioned. And the starting point is also a very simple correlation function, which is an exponentially decaying function. So essentially, the spatial correlation decreases exponentially as the distance between locations increases, where we have a scale parameter phi that regulates how fast this is going to zero. This is a pragmatic decision that we make when we analyze this kind of data because count data are very noisy and not very informative of the spatial correlation. As I said, the geostatistics was developed, before in other areas before epidemiology, and in those areas, especially when we analyze climate data with satellites, you have highly dense data on a grid. So you have a huge amount of data that you can really use to infer all sorts of nice spatial correlations, but with counts, very sparse count data, because you cannot, constrain people to live on a grid. And also a count is not really a direct measure of the phenomena you're trying to investigate. We want to quantify the disease burden through a diagnostic test, and then we have to cope with all the sensitivity and specificity that come out that are attached to that test. So essentially, working with these methods in epidemiology is a lot more difficult than when people have applied them to other fields of science, where there is a lot more data and also that are more informative. And this is an issue because sometimes people simply take those methods and transplant them to epidemiology, and they don't work because they are very highly parameterized models that require a lot more data and more informative data than we have. So to really go to the point of what this model is an extension of a logistic regression, to put it in very simple terms, where essentially we are assuming that in addition to the effects of covariates, so D transpose beta there, we have this additional effect of S of X, which is the spatial Gaussian process. And that's all really a geostatistical model for Planck mapping. There is nothing more to say. So it's not, physics, I think, is more difficult than this. But then there are other challenges that I think come with using these models, which is that fitting these models is not easy. It's computationally quite challenging because before I said I was analyzing a data set with 14,000 locations, meaning that if you start computing, all the paired distances between locations, you end up with a 40,000 by 40,000 covariance matrix, which it's going to take a very long time to fit. So when I analyze this data, I used an approximation of a Gaussian process. Essentially, there is another area of statistics where I worked I didn't work much on, but enough, I think, to be able to essentially develop approximation for this. So rather than we are essentially trying to approximate this Gaussian process in ways that avoid the computation of this huge covariance matrix. Okay, and I don't know if you ever worked in this area or heard about the package INLA, but for example, that is based on stochastic partial differential equations, which corresponds to an approach that approximates the Gaussian process. Okay, that's why it's very much used these days, and that's another argument of discussion. But the way that I approach the estimation problem is a bit more different than I think what most people do. First, because I like to develop my own code because I know what it's doing and I can edit it as I please. So there is an R package called the risk map, where all these methods are available, and I will talk about that briefly only in a second. But I use Monte Carlo maximum likelihood, meaning that I don't use a fully Bayesian approach where you have priors for the model parameters, but instead I work with the likelihood function. So I use maximum likelihood. And these methods are, my first package was called PrevMap. It has now been superseded by RiskMap. And there is also See if I can do. Is there a plus there? I'll just do it here. I just want to show you that I have already said this to you by mail. So there is if you go to this web page, nbgr.org, put this in the chat, you have a draft of a book, and also the final book will be placed on this link on the use of an R package for doing geostatistics. Okay, and I think I need to go back. No, finger cross. Okay, so yeah, there is just okay. So there is a book, and the link is available there. I'm just putting this in the chat if you're interested. So if I will update the book at this link, and the final version of the book will also be there. But just to say, if you're interested in developing skills in this area, you want to be able to use this R package, we can talk, but all the stuff, code, data, is going to be at that link. Okay. And so here again, trying to explain a bit more about this idea of using exceedance probabilities. It's a very simple idea, honestly, and it's not. It's something that probably most statisticians find it very okay. So what's so magic about this? But the thing is that for epidemiology, this is quite quite a shift in their thing, and trying to, I think, really make the case and convince them that this is a better approach than using estimated prevalence and prediction intervals. And for example, some people were just using prediction intervals and then see if this 20% threshold, if essentially this confidence interval was above or below this 20%, and if you contain 20%, then it's not statistically significant. So they were trying, I think, to reframe almost this problem of exceeding 20% as a hypothesis testing problem, but it isn't an hypothesis testing problem. This is a really prediction problem. And so we should be working with the probability that disease prevalence exceeds this threshold given the data, which we call in Bayesian statistics posterior probability. So this is the results. And I've used this many times. And again, for epidemiology, this has been quite, almost a new thing, but although it's a very not so new in statistics. So then there are some extensions of this model that I just mentioned. And here I'm going to briefly mention a few, but this is not an exhaustive list. So the first, probably most obvious one, is spatiotemporal geostatistics. Essentially, trying to build, not just the spatial correlation, but also the temporal correlation into the analysis. And with diseases like malaria, this is very important. And I say like malaria because neglected tropical diseases actually don't have a very strong temporal signal. I mean, most of the variation, I think, in neglected tropical diseases is probably due to MDA, because these are diseases that without any intervention, in theory, would reach an equilibrium distribution, and nothing, there isn't seasonal variation, essentially, for most NTDs. But for diseases like malaria, especially in highly endemic places, you have very strong seasonal element that needs to be accounted for. And you then you can also extend your geostatistical model to account also for these seasonal effects. Now, there are many different ways on how one can do that. So this is the paper where I essentially explain, at least I give because this is, I think, important point to make. Statisticians have different answers to the same problem, and not, and there isn't a wrong and right answer. So in the references that are on these slides, this is what is I would consider my answer. But I think it could also offer, I think, ideas on how to do it differently. And I'm not saying it's the only approach, but I think let's say my approach is trying to develop models that tend to be interpretable and not just focus on develop the best predictive model. I tend to care, I think, more about interpretation and the interpretability model, and not just about predictive accuracy, essentially. So here, just a bit of context of this map. This is malaria in a district of Malawi called Chikwawa. I spent there a few months when I was doing my PhD. I mean, you can see there are these two areas of red and green. So in the red zone, you have very high prevalence, and so here there was a thing that no covert was able to capture, which was an escarpment that essentially is following the blue line, which is quite a big river. And there is this escarpment that acts as a barrier. So when there are floods, the eastern part has many mosquito breeding sites, and the western part has very few or none, actually. But really, elevation or anything that was coded as a covert was not very well capturing this. And that's why here we need this additional ingredient, essentially, of S of X, this spatial process, because it really can capture also these effects that cannot be captured by measured covariates. The other point is that you can see temporal variation, and especially if we look, these are the Junes in different years, and you can see that overall, actually, there is a kind of decline of prevalence in this area. Some people say that now it's going up, but I don't have the updated data. So the other thing that I worked on is on combining data from multiple diagnostics. So essentially, I think about two different problems. When we want to predict a gold standard diagnostic using a cheap diagnostic. So going back to the problem of river blindness, I said before we were analyzing nodule prevalence, but I said the gold standard is the biopsy. So for example, we could develop a joint model where in some locations we could have both type of diagnostics, but then in other locations we only have the cheap diagnostic, if you want, nodule prevalence. So how can we use this information and the data where we have, the locations where essentially we have some overlap between the two to develop inference of what would have been the gold standard outcome at those locations where we didn't do the gold standard. Then there are, I think, another problem in combining diagnostics where essentially there isn't, we're not talking about gold standard and a cheap diagnostic, but where actually both are of interest and they bring kind of complementary information. For example, parasitemia and serology. These are two interesting way of carrying out a diagnosis. They give very different kind of information. One is about cumulative exposure, serology. Parasitemia is more about recent infection. So how developing essentially joint models for diagnostics that are both of equal interest, but try and reduce the uncertainty by developing a joint model. And again, geostatistics is useful in this case because with geostatistics, we don't need both diagnostics to have been measured at the same locations. All we need is to have the information on the locations. We can exploit the information on how distant they are to correlate them. So having both diagnostics at the same location is not a requirement, essentially. The other is structured zero inflation. So, for example, this is, I think, an issue of geostatistical analysis for several neglected tropical diseases because these NTDs tend to be, in some areas, very low prevalence, and it's still unclear where are the endemic boundaries of these NTDs. Essentially, there are studies where they end up surveying a large swathe, of a country where there is no disease. Okay, so it's actually a disease-free area, but because it's an unknown aspect of the disease, they have these big chunks of data sets where actually there is loads of communities without any infection. And this is, I think, a nice example where we have Sudan And that's the Nile, blue and white, and well, what are the two Niles river? I don't remember. White, blue Nile. Well, anyway, it's the Nile, and then it forks into other Niles. But it's so this is a clear problem of spatially structured dream relation, because you have first an ecological area where you have a bit of a savanna, essentially places where there is a vegetation, and also other environmental conditions that favor the presence of black flies. But then as you start to get closer to the Sahara Desert, these environmental conditions become less and less favorable to these mosquitoes. And so you have many locations where actually you have no, so the green locations where you have no disease. So there are two processes here that one needs to model. One is the suitability of the place to actually have the disease, and the other one is, given that it is suitable, how severe is the disease. So there are two spatial processes here to model, and that's an approach that we have explained in this paper. There is also other, I think, future methodological directions, and tomorrow I'm going to talk about one that I honestly find the most exciting these days. I'm really fascinated by immunology, and I'm trying to develop multivariate geostatistical methods that can allow us to map antibodies, essentially levels, but trying to also correlate different antibodies. There is, I think, a lab. Well, no, I think so. There is now what is currently being used in some countries also for surveillance are so-called multiplex device. So these are devices, lab devices that allow you from a single sample of blood to diagnose tens and tens of diseases at the same time. So they are very efficient in the way we can understand clustering of diseases and then map them. There are some issues in having these multiplex being used across all over sub-Saharan Africa, because you need to also have the reagents for the labs. You need to have the staff they trained, and the maintenance of all the equipment. So there are issues, but it's something that is taken over in some places, and there is, I think, an interesting new methodological development that needs to be done on how we analyze this data. And I think it's going to be more important, because I think this kind of data will allow us to develop integrated ways of surveillance. And I think because of the shrinking, I think, funds for global health and aid budgets across the world, we need to help countries to use advanced statistical methodology to make, to develop integrated surveillance. So rather than thinking of a disease individually, we need to think about how we can, I think, monitor and then intervene to eliminate diseases jointly rather than separately. And I think there is I think a first answer that we can get by using serological data. Also, the other one is I'm interested in, which is a more methodological, how we can incorporate mathematical models into geostatistical models. So when I refer to mathematical models, I refer more to assumption-driven modeling, and which is very useful when you want to project into the future, your risk map, but assuming some control intervention, essentially control scenario simulation-based modeling, which can also be incorporated with geostatistics. And we have a few examples of this for lymphatic filariasis, because mathematical models are very disease-specific, unlike geostatistical models. So for every disease has its own group, developing a very specialized model for this disease. And then we can then provide our geostatistical analysis as input to those models that can then do the projection. So essentially help also mathematical models to start from something that's probably closer to the ground truth. There are also issues of how we do validation of these models. There is I'm not, for the sake of time, I'm not going into that, because I only have 2 minutes, I realize. The chapter 3 of the book you find. Yes. Okay. So now I'm going to talk about, I think, my policy engagement. I mean, I still, I'd say, quite a bit of a novice in this area. And so these are my very first efforts. And the one that I have been working a lot has been trachoma, which is another neglected tropical disease. It's a lot, I think, for me at least, epidemiology, this is more complex than river blindness, because here the ways of transmitting this disease is also mostly driven by poor hygiene and sanitation, but there is also the potential role of a fly here that that can play a part in the transmission of this disease. But there is also a direct human to human infection route, and then there is one where there is also a mosquito mediated route of infection. And depending on which one is dominant, sometimes we can see in the data a stronger spatial signal than in other cases. So the way we have been using geostatistics is now also to infer at an area level. So using still point level data, we can also infer what would be over a spatial unit used for decision making, what is the prevalence for the whole unit, the average prevalence. And here we have been using it. Before we were looking at the exceedance of 20%. Here instead we are looking at the non-exceedance of, how much is it? I remember, I think it's 1%. Okay, so essentially declaring the elimination of disease based on the probability that we are below a threshold. And so here we have the examples of Brazil, an area of Malawi, and Niger. Okay, so, and here we supported programs to help them develop their WHO dossier, where they were essentially informing based on a geostatistical analysis which evaluation units have reached the elimination, based on the evidence data, are likely to have reached elimination, and which instead have not. So geostatistics, although for me as a statistician, honestly, because I have been spending time doing statistics in my undergraduate studies, to me this is really like reading a book. Okay? It's not it's very easy, but if I look back and see how much time it took me to reach this level, it's it's something that really it's not possible to do these days, to reach the demand that there is for the applications of this method. So how do we essentially address this challenge of training people, but but without taking how much 10 years, okay, to reach this kind of skills. Yeah, so and I think there are different ways that we can do. So the simple one is to identify key people in some countries, especially sub-Saharan Africa, local champions, local biostatisticians, that we can train them. And because they already have some training in statistics, we can essentially don't need to spend that time to teach statistics, but we can just start with statistics straight away. So how we, that's the probably most obvious way. The other one is also how we can help non-statisticians to use them through the use of user-friendly interfaces. So essentially avoid the need to do training, but actually learn to training in geostatistics, but train in the use of an app that implements geostatistics, and only help the person that uses the app to understand how it functions, but also how the results should be interpreted. And this is this is work in progress. There is an app that I could show you, which I developed for malaria, and my colleague in Birmingham has also made, I think, huge advances with respect to the one I developed malaria, and he has developed one for the whole of the NTDs, and it's a Gates-funded project that is still ongoing. So we had a workshop in Lancaster in March 2024, where we had people from different countries, Sub-Saharan Africa, and other stakeholders to understand essentially how we can make geostatistics more accessible to countries, and what role WHO would play in helping with that. There is a meeting report that's been published, I'm happy to share. We had another meeting in 2025, which is more related to how we can build the geostatistical capacity through the establishment of so-called geostatistical hubs. So essentially have centers of excellence in different parts of the globe where there is this expertise in geostatistics, and that could help support countries, not just in the country of where the site is, but more in say WHO region. I mean, this is still, I mean, an idea, I'd say, other than that we are still developing of this idea of hubs for geostatistics. Yeah, I mean, now things have stalled because of recent geopolitical events, which make this even more challenging because there is even now less money to implement this approach. But it was an idea. I'm happy to discuss more. This is the app I mentioned before, but given well, I have 5 minutes, and I think it's really worth going to see this. But if you can link on that, and then you can, there is a demo on how this app works. This is a very very early stage user-friendly interface where the idea was trying and support countries to do spatial temporal geostatistical analysis for malaria. Okay, I mean, so before I get to the questions, the issue with developing user-friendly app is that how much freedom you want to give to the user, because ideally you'd like to give them as much freedom as they can, so that they can do analysis that are more tailored to their specific questions. But if it's a non-statistician using that app, there is a risk that they may end up doing a mess. And actually, this is then rather than helping them, we are actually, causing more job for us and actually even, causing more problems, as you can see. So I think that there is it's where is the right balance on how much, flexible these user-friendly apps should be is a point. I mean, ideally, we'd like to have a kind of chat GPT user-friendly app where essentially type in what you need, and then the app is, the AI behind is able to understand what kind of statistical analysis they need. But I don't think we really have reached that stage now. I think that the stage that is credible for us now is to have more kind of, finite option selection windows, where essentially we ask a question and then the user only can select a finite set of options. And based on this, we can then, have a decision tree where we select exactly what kind of analysis they need. I don't think we can really, but even this is not an easy way to do it. But to me, this is the only credible approach we have now. Ideally, in the future, it would be like, working with generative AI. Yeah, so that's all. Tomorrow I'm going to talk about more about a non-geostatistical problem that I hope to turn into a geostatistical one, which is about serology data analysis, and it's going to be more technical. So thank you for listening again, and I sorry if I've taken a bit too much. Okay, thank you. Are there questions? Yes.
Thank you for the presentation. Do you have any other louder? Sorry, I hear you. Yes, sorry. Thank you. Do you have any other approaches for spatial correlation other than distance-based? Or is that something we'll go into?
So I would say this. Okay. First, the instance where it's a simplification that we make, but it works most of the standard cases. It works. Now, it is questionable. For example, if you have, let's say, if you have two communities, and then in the middle there is a lake or there is a mountain. Okay, of course, it's not going to be credible that the distance is going to correlate them, but that's why this assumption is based on the residuals of the model. So essentially, what is in the model is the covariate that has taken out those effects. So we are making these assumptions on the residuals. So that's why it's not as bad as it may sound. Okay.
I'm not saying it's
no. But it's because there is nothing in reality that is correlated through Euclidean distance nothing. So we already know it's a wrong assumption. But because in statistics all models are wrong and some are useful, and because we are making these assumptions on the residuals, I would say it's more tenable if you have covariates that have removed those effects. It's less credible if you don't have those covariates. But even then, it doesn't mean that your predictions are going to be complete crap, okay? There are ways to get around this assumption. And for example, there is a study that I did where actually we in addition to distance based on the locations, you could also think of distance based on socioeconomic factors, trying and think of other dimensions where the distance would make sense, which is not just geographical. Okay, so you can add other kind of correlations essentially that are not just distance based. And then there are other approaches based on SPD. There is a paper by the ILA group that I think have on how to deal with these barriers, lakes or things there. So there are solutions, but my view, you need them in less common cases. Yeah.
Just following on that, like we use distance for a lot of things that are seasonal and endemic, I guess, largely, especially dengue and screw. But in more NTDs or emerging settings, when you have sporadic cases, they might have been spread by like from here to way over here, and it's not circulating as broadly in the population. Have you tested using other metrics in that sort of scenario, or is that even true? Like for a lot of NTDs, I think they're more sporadic, right?
Yeah, they tend to be varifocal entities. So you see these small pockets of infection, but they're quite so.
Okay, so
they're very concentrated. Okay. But I think what I feel like you're alluding to is more like infectious disease modeling, where you can examine the route of transmission, but we don't have really that kind of information that help us to track the cases.
What we're testing right now is looking at the comparison of human mobility versus distance-based or neighborhood matrix in endemic versus emerging settings, where you sort of have different patterns. That's
a very, absolutely valid way to look at this. But here, so there is a mathematical question, which is how do we find the correlation of a stochastic process, which I think is a very different question from how we examine, how the disease is spreading through a community. So here we need to be more pragmatic, because the more fancy the model becomes, trying to account for these nuances, the more difficult it's going to be to estimate it from the data. So that's why geostatistics is heavily pragmatic in its spirit, because it's very difficult to get accurate estimates of these parameters. And even this one that is based on this very simple approach is very sometimes challenging to estimate. Yeah.
So the objective in your geostatistical models would be more to predict for unknown locations, to describe the change in prevalence in space, more disease mapping, or more inference over the parameters, or it can be the three of them at the same time.
Yes, yes, it can be all of those things that you just mentioned. Although I'd say that there is always a tension between predictive power of the model and I would say explanatory power of the model. You can't optimize both. So if you want to use your model for getting good predictions, you may have to lose a bit on the interpretability, and if you want to use more interpretability because you're interested in understanding an association with factor, you may not get necessarily the best predictive model. So there is this tension, and you can do all of them. And geostatistics is important because the other thing I didn't say is that it allows you to, because you account for spatial correlation, the inferences on the regression coefficient, for example, will tend to be more reliable than if you ignore spatial correlation, and they will tend, because you account for this extra source of uncertainty that is then reflected in the standard errors of the regression coefficient. So it can be done to address all of what we just said, but the model can be optimized to address only one question. That's the way I see it.
I know you said you wouldn't talk about the estimation, but like just to get a hint, is it more like a GLS kind of thing?
Generalized linear square?
Yeah, so that how do you work with a variogram and like do you work with empirical or?
I work with the empirical variogram, but it's only a tool that I use to, let's say, at an exploratory stage to understand whether there is spatial correlation in the data. I never use it to draw inferences, whereas I use the likelihood function. To me, is the starting point of any inference method, and I never deviate. I mean, actually, tomorrow I will deviate from this set, so I should be careful what I say. Yeah. Okay. Yeah.
Stuff you were talking about. I was wondering, how do you actually then go to account for things? Well, that's like a measure of if you've been exposed in the past, but that exposure may not have occurred in that spatial location where you have then taken the sample. So are there any ways of like accounting for that? Because it's assuming that your exposure is primarily where you're taking that sample.
That's true. The thing is, there would be a way. So I'll talk about a problem I'm working on. It's not this, but it's very similar, which is about female genital schisto. And female genital schisto, the main driver is the cumulative exposure that you had. So it's essentially say worsening of having schisto for a long time for women, and it can cause a lot of physical damage to their genital organs. And the key point here is how much exposure you had throughout your life to schistosomiasis. And, essentially, we never have information on where this individual has lived during their life. So there is really not much we can do about that. There are really, I think, unless we have more information, either you go to the basic approach, which is I'm going to assume this person has always lived here. The second is probably you could, the exposure could be, you could make an assumption of this person maybe has not moved very far from this area. So you could use, you could essentially do a weighted average of what is, the risk has been the risk within a certain radius over time. But I mean, there is no way of escaping the fact that without having information on where that person has lived, you cannot account. I mean, there is no way essentially to get around this problem. It's a very good question. Yeah. Yes.
It's a great talk. I'm just wondering if you could elaborate a little bit when you mentioned about incorporating the mathematical model, I guess is it compartmentalized SIR?
So there are actually more. There could be those, but the mathematical models that we have been working on incorporating are really disease. So this disease specific, and they tend to be stochastic, not deterministic. And these are models that essentially also tend to take into account migration, the importation of cases, which seems to be quite key for entities. But they are stochastic in nature, not determined. Although, I mean, there is honestly, there is no limitation as to what kind of mathematical models we could use to link with geostatistics. It's just that the models that I've been working on in the context of entities, the majority are stochastic in nature, simulation-based, but stochastic. I mean, I could dig a bit more because now I don't remember on the back of my mind what kind of model we used. It was lymphatic filariasis. Sorry. But the thing is that I collaborate with people who have the expertise in the mathematical field, mathematical modeling field, and I bring this other element of geostatistics. I'm not developing the mathematical models, so yeah.
That's an interesting. Trying to tackle this PhD.
Okay. Definitely. Yeah. I mean, next days, I would hope that I feel, my first kind of was with Anya in Oslo, and I thought your group is doing, I mean, things that are so close to what I'm doing.
Yeah,
so it's a shame, if we don't work together. Yeah. Yeah. Yeah.
a quick question about the trachoma.
Yeah.
So then did they do mass drug administration, and do you get an idea of like how good risks were?
So yeah, I mean, in that case, it's more. I don't think they do. So yeah, they do praziquantel. I think it's for trachoma. Yeah, I mean, the question is actually where can we stop doing that? So it's more. Yeah. So yeah, they based on these maps, so they decide on stopping that kind of intervention in some areas. I mean, the way also trachoma is defined is, you have these two conditions, TF and TT. So there, and for each there are two thresholds, and it's again similar to the case of schistosomiasis because TF is a complication of having had TT for a long time, and so there is a question also how spatial. It's not. I mean, trachoma has been the most difficult NDD to model. Which just honestly the most difficult disease I've been working in using geostatistics because of this transmission. I think is not really, to me, fully understood. And there is both a mosquito vector element, but there is also human-to-human contact. And sometimes, depending, and in places, some may be more important than the other. But the thing is, for geostatistics of use, you need to have a spatial signal from the data. And if that signal is weak, you're not going to be able to do much in terms of geostatistical modeling. Yeah, and trachoma has been very challenging. But the point is then that in the context of trachoma elimination, people tend to resort to very easy things, like we compute how many people, the fraction of people infected, and if this fraction is below the threshold, we make a decision. But even when geostatistics doesn't work, there are still other approaches that, simplified models that can still take into account the stochastic element of the process that you model. But there is this idea, if there is just no geostatistics is possible, that means we just use this, naive approach. But it's difficult then to convey this nuanced idea that actually we are doing statistical modeling, and geostatistics probably is the most complex on a continuum of complex choices that you have. But you don't. If it's not there, you don't need to go to the other extreme. There is something else you can do in the middle. But for someone who's not a statistician, this is very difficult to understand. I mean, not that they're sorry. I'm not describing these people as if they're complete ignorant, but okay.
I have one last question, maybe. So you mentioned that you haven't noticed a lot of seasonal variation with most NTDs, and you mentioned something MDA, which I don't know what it's. But yeah, could you maybe elaborate on that a little bit?
And I will elaborate also. Okay. This is a preprint on how to do spatial temporal modeling of entities. Did you? I don't know if I shared this with you, but just there's a graph here that I really like. Sorry. So essentially, when there is if entities have this equilibrium distribution that is assumed, okay. But what essentially breaks this equilibrium is these human interventions on the disease, which is giving essentially these drugs mostly to anyone, regardless of their infection status. And so here, in this paper, we are describing a spatio-temporal model for NTDs where there is this time variation. But our assumption is that when there is an intervention MDA, so then this leads to an effect, which is almost, it can manifest in the number of weeks, where it reaches a peak, which is when the MDA has its highest impact, and then with time this goes down. And when you then do the survey, you're going to do it at some points of this curve, this black curve. And so depending on when then you monitor the disease, you will see changes over time. But these are not natural changes, like due to the temperature. So it needs to be modeled differently, this time variation in NTDs, because it's not it's human, mostly it's human caused temporal variation, not environmental driven. variation. So we proposed here an approach on how to account for in a different way than to not just use standard spatial temporal modeling, but do it a bit more nuanced to this type of diseases.
This distribution.
Exactly that.
And when you account for this, is there seasonality or also?
So I wouldn't call it seasonality, but we can recover what is the MDA impact function. And for example, soil transmitted helminths. They can help understand what is the impact of MDA for different species of STH. So here, for example, we have the 3 STH species: Ascaris, hookworm, and Trichuris. And here you can see the MDA, for example, tend to be. So here the higher is. So this is the relative reduction in prevalence after MDA. And so the higher the curve means you have the almost more than 75% reduction in prevalence after you do MDA. But then it's going down more quickly. Whereas for Ascaris, it's less effective, but it's more long-lasting. And for Trichuris, it's actually the least effective, if you want. It goes down quickly. Yes, so it's not, so you see essentially this kind of bouncing back, which is over not matters of months like seasonal, it's years. So here we're analyzing data that spans more than 30 years for each, and then we see this bounce back to some previous levels just because in some areas they stopped MDA and so forth. So it's not seasonal, it's more depending on how much MDA they have done in the past. Yeah.
I was just wondering, you model, I assume, as a covariate the time since the last massive, more than, even if you have more than one, I assume.
Yes. No. So this is a very simplified graph, but the model is accounting for the specific timing of each past round of MDA, and then based on what. So when I observe something at this timing point, I take into account the time that passed since each previous round, not just how many rounds. Yeah. So I started with a very basic logistic regression geostatistical model, but then there are so many possible directions they can take and be extended, and that depends on the disease, sometimes the research question, and so forth. Yeah.
Any more questions? Okay.
Let's end it here.